Now we'll go on to Obs and Gynae. Pediatrics finished for now. So pediatric stations. So let's go with. So to start with, we have preeclampsia, we have PID, we have STI, and we have contraception station. Then we have ectopic pregnancy. So let's go with preeclampsia first. VRF2 in OBG patient age 29 who is 36 weeks pregnant, referred to the hospital. Vitals, blood pressure 160/110, urine protein is positive. First booking, blood pressure was 110/70. And talk to the patient and discuss the management. So what you have to do here, so the patient has come in with 36 weeks of pregnancy and she has got high blood pressure now, which was not there in the first booking, and urine protein positive. So now what you have to do, first you have to take history of the pregnancy itself. So how was the pregnancy been all these days? Is there any complications in the previous pregnancies? All those things. So pregnancy history first. And then you talk about associating symptoms associated with preeclampsia and any complications of preeclampsia that might be already there. And then you tell the patient how do you manage preeclampsia. So what are the associated symptoms now? So you have taken the pregnancy history first. So antenatal visits. So what does pregnancy history include? So whether it is the first pregnancy or not, and how is the pregnancy so far? Any complications? Any infections? Any high blood pressures before? And any antenatal visits? So all those things. The pregnancy history, then associated symptoms of your preeclampsia. So what would be the associated symptoms? So tummy pain, nausea and vomiting, headache, visual changes, then swelling in face. So sometimes you can also see vaginal bleeding. So these are the associating symptoms which you ask when taking history of preeclampsia. Then, so what are the risk factors for preeclampsia? So the first one, which we all know, will be the first pregnancy, then any family history of preeclampsia. So smoking alcohol and age more than 40 years of first pregnancy will also lead to preeclampsia. Examination. So preeclampsia, you have taken the history, you have taken pregnancy history, you have taken associated symptoms of history. So now we have to do the management. So management includes examination, investigations, and the treatment. So examination, you do general physical examination, vitals, obviously, examination of the abdomen. Then investigations. What investigations? Routine bloods, urine proteins, ultrasound scan, and CTG. So why CTG? You have to make sure the child is doing fine. So what is the main problem of preeclampsia? Is premature birth or try-uterine death of the child. So you have to be very careful. So you have to do ultrasound scan and CTG to make sure the child is doing fine. So now, what is the management for preeclampsia? So as such, preeclampsia, we have to make sure the blood pressure is coming down. So for that reason, what you give? You always admit the patient and give antihypertensives to reduce the blood pressure. But if there is, by any chance, if the preeclampsia turns into eclampsia, getting fits or anything, then you have to give magnesium sulfate. Okay. So in this preeclampsia station, the patient might be not happy to be admitted in the hospital. So sometimes you might get the patient at 36 weeks, sometimes you might get us 38 weeks. So what is the management if the patient comes with 36 weeks, and what is the management if the patient comes with 38 weeks? So for 36 weeks, you observe, you try to reduce the blood pressure, and you have to be vigilant about the preeclampsia going into eclampsia, and then you deliver then after 1 week. But if the patient comes with 38 weeks of pregnancy, then you always deliver the child immediately, regardless of the blood pressure or anything. Right, so 38 weeks, immediate delivery, 36 weeks, you try to reduce the blood pressure, wait till the child completes 37 weeks, then you deliver. But if at any place, any time, if it is turning to be severe or if there is eclampsia, you deliver straight away. So contraception. So we have one session for contraceptive advice. So there is a patient who has come to you asking for advice regarding contraception. So what would be your advice? So first things first, you always have to ask, what does the patient know? So always get knowledge from the patient, what she knows, then you can advise in a better way. So when you ask, what does the patient know, how many types of contraception does you know, or she has any particular contraception in mind which she wants to talk about. So ask those questions first, and then after coming to a conclusion of, okay, fine, so you want this contraception, so once the patient does, no, doctor, I want to take this contraceptive thing, so explain or talk to me about this, then what you try to do is, you try to take some history to see if there are any contraindications for that contraception. So if there is no contraindication, you can prescribe the contraception and you can send the patient home. But if there is contraindication for that type of contraception, so you always try to give some alternative to the patient who comes to you for advice. So let's go. F2 in GP, patient age 29, came for the advice on contraception. Talk to the patient and discuss the method of contraception. So first things first, again, as we spoke, so what does the patient want? So what type of contraception she wants, and what is she using or anything already? So if she is using anything already, what is she using and why does she want to discontinue that? So these are the first questions which she asked. Then ask her whether she has completed the family as she is going for contraception, and if, for example, if nothing is working out for her, then that means if all the methods of contraceptions are contraindicated for her, then we might have to go for sterilization, which is a permanent solution. So that's the reason why I asked about her family as well. If she has completed her family, then we can advise her about sterilization. So if she hasn't completed her family, then we cannot advise her about sterilization. Right? So whenever you're prescribing some contraceptions, so you always have to make sure the female is not pregnant, and you have to ask about her periods, because the major side effects of contraceptives are irregular menstrual periods. So you always make sure this periods are regular, no complications, and if it is not pregnant. So what's the last menstrual period? So how do you take a menstrual history? So when was the last menstrual period? So are they regular? Is there any bleeding between the periods, or if there is any pain during or after the sex? So this is how we take menstrual history. So yeah, so what happens in our station? So the patient, as soon as she comes, she wants to talk about pill. So what is a pill? The pill is a general term for combined contraceptive pill. So estrogen plus progesterone. So as there is estrogen in that, so now taking that story, you asked you to talk about COCP, combined oral contraceptive pills. So now you have to rule out if there are any contraindications for the patients. That's the reason why you take history. So what are the common contraindications for estrogen? So first one will be DVT, smoking, and overweight. So if you get any of these in the history, then you have to suggest a different contraceptive method. So when we are taking the history, so in the past medical history, the patient has DVT before and she is a smoker. So that's the reason why you tell the patient that, so this is not suitable for you, so let me advise you some other methods of contraception. So what are the other types of contraception? There will be pill, there will be male condom, there will be female condom, there will be diaphragm, there is cervical cap, there is device, there is implant, there is sponge, there is injections, there is vaginal ring or patch, and there is emergency contraception, there is sterilization, there is natural family planning, and you can use some spermicides. So whatever out of all these contraceptive methods you suggest, and whatever the method the patient might choose, so you should always advise about STIs and the use of condoms. We always have to advise them regarding STIs and the use of condoms. So whatever the other, except condoms, whatever else they use, they are not protected against STIs. So this you have to always advise them before giving the contraception of their choice. Right? Okay, so now what options do we have? So again, some other important questions before you prescribe or you advise anything. So you always have to ask about what type of contraception is she looking for. So for example, is she looking for some tablet forms, or is she looking for some injection forms, some implant forms, some intrauterine devices forms? So you have to ask that. So is she looking for what type? So is she looking for tablet type or implant type? And there's one more thing about time frame. So is she looking for some contraception which she has to take daily, or is she looking for some contraception which she don't have to worry about months, or some contraception which she don't have to worry about years together? So depending upon all these things, you can advise her contraception. So for example, if when you say is contraindicated, so obviously you will give progesterone only pills, which is mini pill. So Depo-Provera, implant, IUS, IUD sterilization. So sterilization, as I told you, if the family is complete, then you can offer sterilization, tubal ligation, or male sterilization. And then IUD, so copper T, so which can be for 10 years. And IUS, Marina, 5 years. Implant, 3 years. Depo-Provera, 3 months. So all these, except the sterilization and copper T, all these have progesterone, which will be released into the body depending upon the time frame. So POP you have to take daily, Depo-Provera 3 months, implant 3 years, IUS 5 years, and IUD 10 years, and sterilization is permanent. So you have to give these options depending upon what they ask for. So if they want something as a tablet form, so you obviously have to give mini pill. And if they say, no, doctor, I don't have to worry about 10 years, so you can advise IUD. And say, the doctor, I have finished my family, so I don't care about anything now. I want permanent sterilization, so offer sterilization. So depending upon the patient preferences, you offer. And always remember, you don't give anything to the patient on their own. So you always have to give your options, what you have with you in your hands, and the patient, let the patient pick whatever they want. So always ask, what type of contraception you want, for how much time frame do you want. So depending upon that, you can give your options, and then the patient can select from that. So what are the side effects? What could be the side effects of any contraception? So acne, breast tenderness, mood swings, headache, migraine, nausea and vomiting, weight gain, and disruptive periods. So as I told you, disruptive periods is very important. This is why you also have to take menstrual history before prescribing these. So I would say if whatever you might prescribe, you should be able to talk about some of the contraindications and complications of that particular kind of contraception. So, for example, we take IUD. IUD, there are complications which might happen in the future. So, what are those? One, it can cause damage to the womb, can cause PID, it can cause rejection. They might lead to rejection. Body might not accept the IUD, then there might be chances of ectopic pregnancy, which the patient is always risk of. So you have to mention these complications which might happen in the future to the patient. Right? So now pelvic inflammatory disease, as we just spoke, one of the risk factors for pelvic inflammatory disease would be IUD. So what is pelvic inflammatory disease? So any inflammation around the womb and fallopian tubes. So how does it happen? So any infection which can pass from one parasite vagina into the womb, or any infection or any inflammation coming down from the abdomen into the pelvis. Anything can lead to PID, and even STIs can lead to PID. PID can in turn cause complication of ectopic pregnancy in the future. So you always have to remember these two important points whenever you get PID in mind. Okay, so you're an F2 in A&B, patient age 28, comes to the hospital with complaint of right lower abdominal pain. Talk to the patient and discuss management. So main presenting complaint for PID would be fever and lower abdominal pain. And they can be bleeding or discharge, more importantly, from front passage. So these are the most common presenting complaints for PID. So what would be the DDs you're looking at if you think there is lower abdominal pain? So one will be PID, one will be appendicitis. So if there is right-sided pain, then you can have a differential of appendicitis. But if there is left-sided pain, lower abdominal, then you can have a differential of diverticulitis. And it can be UTI, it can be pyelonephritis. So these are the structures which are present in that area. So we can consider the differential diagnosis of all those things. Okay, so now what are the associated symptoms? So as we spoke, there's fever, shivering, vaginal discharge, vaginal bleeding, more importantly, pain before and after sex, and bleeding during and after sex. So there will be pain, there will be discharge, there will be fever, there will be nausea and vomiting, and there will be bleeding during and after sex. So what are the risk factors? So we just spoke. So one will be multiple partners, which can cause STI and in turn can lead to PID, and unprotected sex, again, same thing. So coil, so now what's the management plan? So you examine first. So what examinations do? You do physical examination, vitals, abdominal examination, bimanual examination, and perspectivum examination. So you also, if there is any discharge, you also send some sample. So what are the investigation? Routine bloods again, the urine investigation, cervical swab, ultrasound scan to see the level of inflammation in the pelvis. So what would be the management now? So it's always symptomatic. For fever, you give antipyretics, antibiotics for the infection itself. So this will be the major scale of treatment for PID, but the treatment doesn't end there. As I told you, your job in the NHS is just not to treat the patient in the hospital and send them home. You always have to support them even in the community outside the hospital. So that's the reason why you always advise the patient that your partner also should be examined, investigated for sexually transmitted infections and treated if he is found to have an STI. And then some general advice. What is the general advice? Always use condoms when having sex to avoid STIs or PIDs. Then we always offer HIV to any patient who comes with PID or STIs because they will be having multiple partners and they will be following unprotected sex, so it's always better to offer them. So again, here you don't do HIV test before asking the patient, so you always ask the patient when you do HIV test. So you have to income clinic. Patient age 24 has come to the clinic for her investigation results. So swab has been taken and the result shows gonorrhea. Please talk to the patient, take sexual history, inform patient about the results, discuss about further management, and advise the patient. So here you are in gum clinic and the patient age 24 has come to you for her investigation results. So why the patient has come, what investigation have you done? So patient, she has come for you to get checked for STI because she has seen somewhere that she thought that she might be prone to having STI, so that's the reason why she has come to you and she has done some investigations for STI. So now you have the results, so she has come to you to get the results back. But so now what you have to do is talk to the patient, take sexual history, inform the patient about the results, discuss about further management and advise the patient. So now what you have to do? As soon as the patient comes, so you have the result now. So before disclosing the result, so you can just talk to the patient, telling, okay, fine, let me ask you a few questions and then I will give you the results. So you take sexual history. So what sexual history do you take? So everything starts from first, whether she is sexually active or not. Are you sexually active? Do you have a stable partner? Any multiple partners by any chance? Do you practice safe sex or not? So you ask all the sexual history questions. And then if you find anything positive, and at the end you obviously have to advise accordingly. So if she's not following safe sex, then you have to advise accordingly. If she's having multiple partners, then you have to advise accordingly. Right? So now you have the result. So you tell the result. So the result states she has gonorrhea. So now you have to tell how are you going to manage the gonorrhea and what you have to do in the future. So how do you treat gonorrhea? So you give antibiotics and she should be avoiding having sex. So you will be giving antibiotics for a week. So in that 1 week, she should be avoiding having sex. And after 1 week, she should be getting checked again. And if the infection is clear, then she can resume her sexual activity. And you always advise about safe sex in order to avoid getting sexually transmitted infections. So again, to finish the treatment, what do you have to do? You have to always call your partner, get him tested, and if he is positive, then he also has to be treated in order to avoid her getting the STI in the future. Because if the partner is not treated, then again she is at risk of getting infection. So this is a cycle. So you have to treat the patient here as well, and also you have to think about after discharge. Okay. So this is about gonorrhea. So you have the result. You have to explain about the result and take sexual history and find out why she has got STI. So she has multiple partners. She doesn't use condoms. So you have got all the positive findings to say that this is STI because of so and so things. So and now you have to follow so and so advice. Right. So now you've got ectopic pregnancy. So ectopic pregnancy is pregnancy anywhere outside the womb, the most common in fallopian tubes. Okay, so anywhere, so these are the points where you can see ectopic pregnancy outside the womb. So you are ready to in OBG, patient age 20 came to the hospital with left iliac fossa pain. Talk to the patient and discuss management. Patient is with 6 weeks amenorrhea and pregnancy test has been done and is positive. So pregnancy test is positive, 6 weeks amenorrhea, patient with left iliac fossa pain. So what will strike in your mind? So it is nothing but ectopic pregnancy. So what will be the associated symptoms? So it will be pain, bleeding, nausea, and vomiting. Right. I think let's know the difference between ectopic pregnancy and miscarriage. So painless bleeding will be miscarriage. Pain and bleeding will be ectopic pregnancy. And there's always nausea and vomiting. What are the risk factors for ectopic pregnancy? So we have just spoken, multiple partners, STIs, PIDs, previous ectopic pregnancy, IUCD usage. So all these things can be risk factors for ectopic pregnancy. So now how do you manage ectopic pregnancies? What are the investigations and all? So examinations, same again, general physical examinations, vitals, abdomen examination and bimanual examination. Very good. All these examinations, then investigations will be routine blood test. So what will you be doing? A special blood test here is beta HCG. So you check for routine blood test and beta HCG, and also you do an ultrasound scan to locate where the pregnancy is and the size of the pregnancy. So now you already got pregnancy test positive, 6 weeks amenorrhea, and now she has got plain. So she is ectopic pregnancy. So why are you still doing beta HCG? So depending upon the value of beta HCG and the size and location of the ectopic pregnancy on ultrasound scan, your treatment will be depending upon. So what are the treatment options available? So symptomatic as always, any signs of any sepsis, any fever, any pain, dehydration. So symptomatic treatment as always, all the conditions. And for the ectopic pregnancy itself, so we have 3 options. So one will be wait and watch. So if the beta HCG value is low and the size is small, and it's in the fill-up interview, always wait and watch for the pregnancy to come out by itself. If not, then the second option will be medication. So you give medication for the pregnancy to terminate, and the last option will be surgery if the size is too big, beta HCG levels are too high, and if the location of the pregnancy is in a complicated location, then we obviously have to go for the surgery. Done. Now we have miscarriage. So as we just spoke, miscarriage is painless. So you are an F2 in antenatal clinic. Patient age 28 comes to the clinic for the first antenatal checkup. She is 6 weeks pregnant. Vitals, blood pressure 130/80, pulse 70, urine test negative, protein and infection. What are the causes of miscarriage you can think of? So it can be first trimester. So there can be any chromosomal abnormalities. So there can be any placental problems. And age, elderly primary, obesity, smoking, drugs. So all these things can lead to first trimester miscarriage. So second trimester, long-term health conditions, diabetes, hypertension, lupus, kidney disease, thyroid, infections like rubella, CMV, food poisoning, any medications, misoprostol, and structure of the womb, weakened cervix, and polycystic ovarian syndrome. If we have 3 miscarriages, then we do further tests to find out the underlying cause. So the reason why they are giving this station is to find out whether you're going to investigate and do something if there is any miscarriage or not. So we're usually looking for 3 miscarriages to happen unless and until we do any further investigation. So if there is no complication, if there is just miscarriage happen and there is no severe symptoms from the patient, then you don't do anything. But if there are 3 recurrent miscarriages, then you obviously do investigations to find out why. So what we are looking at: investigations, ultrasound scan, karyotyping, and blood test. So management will always be lifestyle modification for the first 3 times. But if it is the 4th time and if there is any diagnosis of any condition, so you have to treat that condition first, and then you have to advise the patient to get pregnant. So thank you very much. I hope this session was very informative. And I think I'm a bit fast in the obs and gynae part. So thank you for your patience. See you next time. Thank you very much.